Hello everyone, this is Belinda Thomas. I'm here to discuss temporomandibular joint arthroscopy. Arthroscopy means looking into the joint and is derived from arthros, which is joint, and scope into view. Temporomandibular joint arthroscopy is a technique for direct visual inspection of internal joint structures and to perform surgical procedures under visual control with the use of an arthroscope. The first TMJ arthroscopy was done by Onishi in Japan in 1974. Individuals suffering from pain, tenderness, clicking, or locking in the jaw joint may be diagnosed with temporomandibular joint disorder. TMJ anatomy. TMJ is classified as a synovial joint, which means that it is comprised of a joint cavity of ligaments and articular cartilage and is enclosed within an articular capsule lined with synovial membrane. It is a functional diathesis, which means it is freely movable. There are 6 types of synovial joint. TMJ is classified under 2. One of them is hinge, which is unicycle movement, and plane is the other one, side-to-side movement. TMJ is the temporal bone of the skull and of the mandibular. Bilateral joint means that there is one on each lateral side of the skull. Components associated with the temporomandibular joint on the mandible include mandibular condyle to the posterior, followed internally and externally by the mandibular, angular, and the ramus. Components associated with temporomandibular joint on the temporal bone include mandibular or glenoid fossa, the zygomatic process, and the xyloid process. Mandibular is the movable bone of the joint. The primary articulation of the TMJ is between the mandibular condyle of the mandible and the mandibular fossa of the temporal bone. There are 3 ligaments. They act to stabilize the temporomandibular joint. The first is lateral ligament. It runs from the beginning of the articular tubule to the mandibular neck. It is a thickening of the joint capsule and acts to prevent posterior dislocation of the joint. Spinomandibular ligament originates from the sphenoid spine and attaches to the mandible. Stylomandibular ligament, a thickening of the fascia of the parotid gland, along with the facial muscle it supports the weight of the jaw. Temporomandibular joint's articular capsule attaches and encapsulates the mandibular fossa and the mandibular condyle. A special feature of the TMJ articular capsule contains articular disc composed of fibrous cartilage that is derived into 2 sections, an upper and a lower joint cavity. Inside each joint cavity contains synovial fluid produced by the synovial membrane. 4 muscles that control the TMJ receive their blood supply from the maxillary artery, innervated by the mandibular division of the trigeminal nerve. Trimandibular joints. There are 2, one on each lateral side. Masseter originates on the zygomatic arch and inserts on an angle on the ramus of the mandibular. Also is a main muscle for chewing. 2 muscles on the interface of the TMJ is known as medial pterygoid and the lateral pterygoid, which helps with the grinding motion. Temporalis, located on the outside of the temporal bone, is the largest of the TMJ muscles. It has a fan shape and more than one action, which is gliding of the mandible. Disc displacement is a displacement of the articular disc in the articular capsule. This causes pain and possible click, or popping sounds during movement. Movements at this joint are produced by the muscles of mastication and the hyoid muscles. The two divisions of the temporomandibular joint have different functions. The upper part of the joint allows protrusion and retraction of the mandible. The anterior and posterior movements of the jaw. The lateral pterygoid muscle is responsible for protrusion, and the genohyoid and the digastric muscles perform retraction. The lower part of the jaw permits elevation and depression of the mandible, opening and closing the mouth. Depression is mostly caused by gravity. However, there is resistance. The digastric, genohyoid, and mylohyoid muscles assist. Elevation is very strong movement caused by the contraction of the temporalis and the masseter and the middle pterygoid muscles. TMJ pathophysiology. TMJ disorder is caused by stress of grinding teeth, malocclusion, trauma, or degenerative or rheumatoid arthritis. Although in many cases these disorders can be treated with non-surgical solutions, surgery may be required in severe cases. Diagnostic innervation. There is no standard test for diagnosing TMJ. Currently, healthcare providers note the patient's symptoms, take a detailed medical and dental history, and examine problem areas, including the head, neck, face, and jaw. Imaging studies may also be recommended. Facial pain can indicate many other conditions such as sinus or ear infections, various types of headaches, and facial nerve pain. Ruling out these problems first helps to identify TMJ disorders. Surgical intervention. Anesthesia uses general anesthesia with nasotrachea intubation. Patient is placed in a supine position. A padded, foam, or gel headrest may be employed to stabilize the head. The head is turned with the affected side up and the dependent ear well padded. A roll may be placed under the shoulder to facilitate tilting the head upward. The other arm is extended on a pad, armboard, or well padded and tucked, placed at the patient's side. A pillow is placed under the knees to avoid straining of lower back. Skin prep. Oral cavity is considered clean. Circulator will check with the surgeon regarding shaving and removing the hair from around the ear. Surgeon may request swabbing with oral antiseptic, which is Paradex. The entire face should be prepped. Extend the prep from the hairline to the base of the neck. Begin at the area of the jaw, working outward and both sides of the neck. Lap sponge placed at side of neck to prevent pooling under the patient. Special care is taken to avoid prep solutions from entering the eyes. A small cotton ball is placed in the ear. Draping. Drape patient with a head drape or drape sheet and 2 towels under the head with the uppermost towel wrapped around the head and clipped. Body is covered with a drape sheet. Incision. Endural, periauricular incision, and submandibular incision is used for the mandibular ramus. Supplies needed: antiseptic mouthwash, antibiotic, ophthalmic ointment, lubrication for lips, cotton rolls or dental pellets, dental sponges 2x2, throat pack, 2 small basins, bulb syringe, normal saline, electrosurgical pen with a guarded tip, cord, holder, scraper, dual tubing pre-packaged for suction, irrigation with tubing clips, 2 irrigation needles, sterile water for irrigating solution, blades, a number 10 and a number 15, needle magnet or counter, stainless steel wire, 25 or 26 gauge, retention bolsters optional, defogger for dental mirror, bone wax, gel foam. Equipment needed: padded foam or gel headrest, extremity restraints padded, suction and irrigation and suction system, dental irrigation system with fiber optic light source, dental ESU electrosurgical grounding pad required, fiber optic headlight and fiber optic light source, ESU monopolar and grounding, laser optional. Instrumentation: TMJ tray, nasal tray, minor orthopedic tray, tracheotomy tray, scissors, biopsy forceps, surgical knife, palpitation hook, straight probe, French number 5, myringotomy suction tip, arthroscope, miniature straightforward telescope, arthroscopic sheath, trocar, cannula, and camera. Specimens: biopsies are optional, preference of surgeon. Wound classification: Class 1, clean wound. TMJ arthroscopic surgery. The procedure begins with the surgical technologist prepping the back table, Mayo stand, and ring stand. The circulator preps the patient's surgical site with the approval of the surgeon. The surgeon and the assistant is gowned and gloved. The patient is draped per protocol. Minimally invasive surgery, also known as MIS, is a technique in which telescopic instruments are introduced through one or more small incisions, in which a narrow tube called a cannula is inserted. There are 5 types of MIS performed, and TMJ arthroscopic surgery is one of them. The surgical technologist moves the Mayo stand and back table to the patient's surgical field. The surgeon calls time out, then marks a straight line between the center of the tragus and the lateral canthus. The first trocar site is marked on the line 10 millimeters from the tragus, 2 millimeters below it. The second trocar site is marked on the line 20 millimeters from the tragus and a line perpendicular 10 millimeters down. Xylocaine 1% is injected into the glenoid fossa site. The first incision is made and the cannula is inserted with the aid of a sharp trocar. The trocar is removed, leaving only the cannula. The second puncture is made into the joint space, allowing the surgeon to establish an outflow of irrigation fluid. In arthroscopy, the anatomical space is filled with irrigation fluid to expand the space for a safer operation. The surgeon can utilize the second port to insert a probe to assist in the examination or to insert an instrument to perform surgery, remove adhesions, loosen bodies, fibrous tissue, open cyst, take biopsies, or contour the bones to smoothen out cartilage. The surgeon attaches the camera to the slender ophthalmic telescope, either a 0 degree or a 30 degree, then white balances to adjust the light color. The telescope is inserted through the first cannula. The image is seen through the endoscope, in which is projected and enlarged onto one or more of the flat screen image systems. Once the procedure has been completed to the satisfaction of the surgeon, the fluid is removed and the assistant takes a moistened and dry lap to wipe the surgical site, then applies Dermabond and 2 Band-Aids. And that's it. Thanks, folks.